This video will briefly discuss the use of evidence hierarchies within the process of evidence-based practice. So we're just going to dive right into this content. Basically, as a nurse clinician, we have to use the best evidence possible to define what our nursing practices should be. However, how do we define what the best evidence is? Not all evidence out there is created equally. Looking at rigorous, uh, methodically done research studies is not the same as just going to ask a nurse based on his or her clinical experience or expertise. So there's a leveling of evidence that we should use for our practice. And obviously, because patient outcomes are at stake, we want to use the best, most rigorous evidence possible. So most of the time when we're deciding what the best evidence is, we use evidence hierarchies to make those decisions. And what these do is they rank evidence sources related to their risk of bias and how rigorous the studies were done. And they're usually presented in the form of a pyramid, with those studies appearing toward the top being the most rigorous or the strongest level of evidence. So when we're looking at evidence or research to guide our practice, we want to try to focus on finding studies as close to the top of the pyramid or the hierarchy as we can. Within any level on the pyramid, though, and I think this is important to note, evidence quality can vary vastly. So just because we have a randomized controlled trial that we're looking at does not mean it's automatically an excellent study. There are definitely issues with various types of studies, and you have to be able to address that by critically appraising every study that you choose to look at with regard to answering evidence-based practice questions. So I actually have an evidence-based practice hierarchy here for you to look at. This is one. There are several different types out there. This one is from Pollitt and Beck and dated 2022. And this is their version of an evidence hierarchy for evidence-based practice, specifically meant for therapy questions. So with these types of questions, we're looking at which intervention is best for a specific outcome, which therapy is best for a specific outcome. So we're specifically looking at interventional kinds of questions. So with that being said, we definitely want to put most of our attention to studies that are experimentally testing our therapies or our interventions. So this all might not make a ton of sense yet, but I do have other videos that will explain what all of these different types of studies are. I'm basically just presenting why a hierarchy is needed and how we use it to define what research we should use for our evidence-based practice pursuits. So the top level is a systematic review of randomized controlled trials. That's what RCT stands for. Basically, that is a very tightly controlled experimental study in which there are usually two groups, but sometimes there's more than two groups. But one group is going to receive the intervention that we're studying, and the other group does not receive it. So you have the experimental group that gets the intervention, and you have the control group that does not. And we compare outcomes between the two groups with the purpose of trying to show that the intervention caused the outcome. So it's a very, very controlled study. And so that's what a randomized controlled trial is. That's actually the second level of the hierarchy. What a systematic review of randomized controlled trials is we take several randomized controlled trials done by teams of researchers on the same topic. So suppose we're looking at an intervention, a smoking cessation intervention for adolescents who are using tobacco products. And we want to do a school-based interventional kind of study to see if our intervention using a school nurse in a school setting is going to be effective at helping these adolescents quit smoking and remain abstinent from smoking for upwards of 6 months to 1 year's time. So what we would do is we would need to actually randomly assign some students to our treatment group, which is going to be the ones who get our specific intervention. and will randomly assign others to a control group, which would not receive the intervention. And we would collect the same data about smoking habits and tobacco product use for both groups and then compare our outcomes after the intervention is complete. And what we would hope to see is that the intervention group that did receive the school nurse based clinic would have better outcomes. They would be smoking less and they would remain abstinent for a longer period of time than those who were in the control group. So that if we just looked at one study like that, that falls on level 2. But what if we have a body of 6 studies all on the same topic done by different researchers on different samples of participants, and they all come to the same conclusion? Would that not be stronger evidence that this type of intervention would work? Absolutely. 6 very well done, highly controlled studies are always better than one study because we have more people in those studies. We have more participants, so our sample's bigger. We have we've kind of leveled off the risk of bias because it's not just one study. 6 different research teams using 6 different pools of participants all come to the same conclusions. That is the tip of the top of the hierarchy. Those are the types of studies that we want to look for if we're trying to determine which intervention is best suited for getting the best outcomes for our patients. Okay. However, those aren't always available on our topics. For example, sometimes it's unethical to manipulate different variables. So, for example, if I'm trying to determine if an intervention is effective at reducing, let's see, medication errors, I can't manipulate medication errors. Okay. Like I can't go make one group of nurses commit medication errors on purpose and another group of nurses not commit medication errors. That would be illegal and unethical. So I can't manipulate that as a variable. So I cannot do an experimental study on that. Therefore, I may only be looking at non-experimental studies. As you see, non-experimental studies where there's no manipulation or introduction of an intervention are located lower on the continuum. So the whole point of this is to find the best evidence. If the tip of the top, systematic reviews of randomized controlled trials is not available, then we need to go down the line and see what is available on our topic. What has been published? What's accessible to me? What can I read and appraise and see, is it a strong study? Quasi-experiments or experiments. So we are introducing an intervention to some people. There may not be a control group or there may not be randomization. So it's not a true randomized control trial. It's not very, very tightly controlled. However, we're still experimenting. So that's still above a non-experimental study. And then you have qualitative research toward the bottom. And the reason for that is right here. We're looking at therapy questions. So which intervention is best suited to get the outcomes we want? So qualitative studies are very valuable in informing nursing science, but they're not as valuable at helping us determine which intervention is best. To answer that question, we need studies toward the top of the pyramid or the hierarchy. So we look at these evidence hierarchies to help us discern whether the studies are strong, rigorous, controlled studies that should minimize chances of bias so that we can look at the body of research and see, what does it say? And obviously, the closer to the top, the stronger it should be. But we never want to make practice decisions based on what one study says. That's definitely not the best evidence out there. And of course, at the very bottom, there are non-research based sources, such as like quality improvement data within a hospital that may support the use of a fall risk procedure. But that's not research. That's just data we have within this one hospital. It's not the same as a full controlled study. Obviously, expert opinion or your clinical expertise, that is evidence. We can use that to base our practice upon, but clearly, studies, well-designed disciplined studies, are where we need to base our decision making. This is not the only evidence hierarchy. There are tons of them out there. Johns Hopkins University School of Nursing has one. There is one by Melnick and colleagues. There are a ton of different hierarchies. I just presented this one because it is in the textbook we're using for my research course. But you need to be aware that when you're reviewing EBP, evidence-based practice, there's usually going to be some descriptions of the levels of evidence. And so obviously, the higher the level, the better. Okay, hopefully this has helped give you just a taste of why we use evidence hierarchies and how you can kind of figure out where a study would fall. You do need to watch further videos or do further readings on different types of designs and what those mean in order to really understand this. This was just meant to be introductory, basically, so that you understood the different levels and why we need evidence hierarchies. So thanks for listening.